All right, welcome back. So, we were speaking about ultra-conservative dentistry. So, in the last class, we spoke about the need for conserving as much dentine as possible, retaining the affected dentine and removing the infected dentine. That means to say that whatever is necrosed, infected, and filled with bacteria, all that is decomposed has to be removed. And whatever is just affected, which is just demineralized a bit, can be left behind, which has the potential to remineralize, and it has the potential to stay disinfected when we do the cavity disinfection. So that basically sums up what we had spoken in the last class. We also discussed briefly about fissurotomy, enamelloplasty, and prophylactic odontomy. Prophylactic odontomy is basically the removal of the pits and fissures and restoring them with amalgam prophylactic, but that is not advocated right now. Ultra conservative dentistry dictates that we preserve as much sound tissue as possible. So we have fissurotomy burrs, which are highly ultra conservative and minimally invasive in their tip design, which makes the fissures to be very narrow yet deep. And thus, these grooves can then be filled using our adhesive resins, that is, our composite resins. Flowable bulk fills can be used in these regions to effectively seal them. Enamelloplasty involves removal of any areas which are like catchment areas. So those you basically round them off using smooth burrs to create something which is a self-cleansing area. So that is enamelloplasty. So now we come to the other techniques which involve a little bit more invasion, but still respecting sound tissue as much as possible. So in that we have the first technique, which is air abrasion. Now this is very similar to what you would have seen in your prosthodontic labs. You have your sandblast. So something very similar there. These are like powder particles which are basically focused on one part of the cavity or on the tooth, and that will selectively remove whatever tissue is required to be removed. So it relies on the transfer of kinetic energy from a stream of powder particles on the surface of the tooth structure, or a restoration to produce a fractured surface layer, a disrupted surface layer, and this results in enough roughness for our bonding procedures. So for bonding, micro roughness is always much better, because that increases the surface area of our cavity prep, and it also creates micro retention tags, which will be helpful for our etchant and our primers or our bonding agent to enter and create dentinal resin tags. So this creates that kind of a roughness, and it also helps in polishing of your stains, or any calculus which is there can be removed using air abrasion, and thus it is also called as air polishing or micro air abrasive polishing. So these powder particles, when they are streamlined on the tooth, create an abrasive effect, and this abrasive effect is helpful in polishing and roughening that area. So as I said, the uses include stain removal. It also helps in debriding the pits and fissures before sealing them. We can also diagnose suspected decay, like incipient carious lesions, which are just about to start off. So you can explore them under the surface when there's caries, like subsurface caries. You can explore them using air abrasion. You can also, as I said, create that micromechanical roughening of the surfaces in order to bond your composite, or in order to bond any of your glass ionomer cements. And also they help in direct access occlusal, buccal, and lingual cavity preparations. So when you have a direct access, you can always use these in order to prepare your cavities, and also to repair the margins of composite restorations whenever there is signs of micro leakage or marginal deterioration. So let's just I'll throw a question at you guys. Let's see who can answer this question. So it is basically a question regarding the pressure level. What is the recommended air pressure for surface abrasion or etching using an air abrasion unit? So if you're using an air abrasive unit, what is the air pressure which is required to surface abrade, to create that micro roughness, to create that surface irregularities? Can someone guess and tell me what is the pressure which is required? right? So the air pressure which is required for surface etching, is it 10 psi, that is pounds per square inch, that is the pressure, or is it 80 psi, 150 psi, or 250 psi? Okay, so the answer to this is 80 psi, right? So the recommended air pressure level for creating those surface roughness is approximately 80 psi. 60 to 80 psi is what is recommended. So if you see, this contains basically aluminum oxide, the powder which is present in this air abrasion. You can see the image in the bottom over here. That shows you the unit, the handpiece which is required in order to deliver the powder particles onto the tooth surface. So this unit basically has a jet which carries powder. These are streamlined onto the cavity or onto the tooth, and this is basically made out of aluminum oxide, and it also has other oxides such as silica, and then it has zirconium dioxide and ferrous oxide and titanium dioxide. So these are the other oxides along with aluminum oxide, with an average size of 27 to 60 micrometers. So as we go higher up in the size of the particles, the aluminum oxide particles, the cavity preparation tends to be larger in size, right? So there is lesser control over the precision. So it is better to use smaller surface, smaller particles in case we are doing polishing, or in case we are doing micro abrasion for smaller cavities. But for larger cavities, you can go ahead and use 60 micrometer particles, which will help in effective debridement of that area. Also, it is released at a compressed air pressure of 40 to 150 psi. So that is the range of the pressure which is used. For cutting, you need to use a higher pressure such as 100 psi or higher. In case you're doing just the surface etching, in that case 80 psi is what is recommended. 40 psi is basically for micro polishing. So remember these values, because these are objective questions that can be asked in your NEET exams. A question related to smart BURS were asked in the previous NEET examination. So this topic is gaining high relevance due to its minimal invasive potential and its ability to generate lesser aerosols, right? Because there is hardly any water involved over here. There is very little aerosol created, which is very significant during this pandemic era. So apart from aluminum oxide, I want you to know that there are other materials also used as the powder particle. So that includes alternative abrasive mixtures which are softer, such as polycarbonate resin. All right, remember polycarbonate resin is a softer material. You also have alumina hydroxyapatite mixtures. So these are more selective in removing only the carious dentine. That is, they are softer. They do not really affect the healthy tooth tissue, and thus they are very selective in removal of soft tissue. Okay, so that leaves only healthier sound tissue which is virtually unscratched, and there is enough of micromechanical roughening for the bonding to happen. So like dental lasers, their use is limited. Okay, it can only be used in small caries lesions, but you can also help use this in helping you to remove any old restorations, any old amalgam, old composite, old glass ionomer cements can be removed. Even cast metal alloys can be polished using air abrasive agents. So these are the various factors which help in air abrasion, which affect air abrasion. It includes the air pressure, water flow rate, that is the flow rate of the water which is being delivered. There is very little water which is required. Powder flow rate is extremely important. The more amount of powder which is released over a shorter amount of time helps in decreasing the treatment time and making your procedure faster. So powder flow rate helps or affects your duration of treatment. Okay, the fine focus of that stream of alumina particles which exits the nozzle permits pinpoint ultra-conservative preparation. So the particle size again helps in deciding how conservative you are in your preparation. As I said, 40 to 50 are generally used for surface abrasions, 40 to 80, and then the ones which are higher than 100 are mostly used for your cutting of cavities. Then the tip geometry, if it's round or oval, that also has its effect on the cavity preparation. And the angle of attack or the placement of your handpiece, that also decides how well you're cutting. The distance between the tip of the air abrasive nozzle and the substrate has to be 3 to 5 mm. Okay, that should be the distance. If you go closer, you can effectively remove more healthy sound tissue, which is detrimental to all the minimal invasive principle we are following. And at the same time, if you keep it farther than 5 mm, then you are effectively not cutting any sound tissue. So the substrate can be any of these following. You can cut using air abrasion on enamel. You can even cut dentine. You can cut cementum, amalgam, composite, casting alloy, and also ceramic. So the motion is generally a scanning kind of a pattern. You run the nozzle above the tooth in a to and fro motion. And this is approximately 12 per second. That is around 1.2 centimeters per second should be the motion of your movement of the handpiece. And the duration is generally more clinician oriented. So few examples of air abrasive units include the Rondoflex by Cavo and Prep Start H2O by Danville. These two are highly used. There's another called as Aquacare, which is used mostly in the Asian countries. These are devices that are used for air abrasion. So the advantages is you are creating something which is more smooth, more rounded. There is internal contours which do not have any sharp line angles. A more rounded kind of a preparation is gained using air abrasive units. This helps in bonding of our ceramics and composite more predictably with a higher successful treatment outcome. It also increases the longevity of the restorations, because once you create something which is more rounded, you have a lesser incidence of fractures, and as a consequence the decreased internal stresses are seen in these angular preparations. So let's compare the high speed drill, that is our aorta, with micro abrasion. We know that rotary burr can cause micro fractures. If you're using it without a good cooling agent, if the water cooling is not sufficient, you have higher chances to create micro fractures. But with micro air abrasion, with just powder particles being sprayed on the tooth, the known potential for micro fractures is almost none. There's also a potential for indiscriminate destruction. That is, healthy tooth can be removed using a high-speed drill because it can cut through tooth uh, just like a knife cuts through butter. But micro air abrasion has increased accuracy in the hands of an experienced practitioner. You can be highly efficient, highly conservative, and just remove what has to be removed. With high-speed drill, the dentist is forced to destroy sound tooth structure in order to accommodate the size and shape of the burr. In order to let the burr sink into the deeper portions of our cavity preparation, it is required to enlarge our axis, and that is the problem with our high-speed drills. But with micro abrasion, extremely small preparations and accuracy is completely different when compared to high speed drills. It is much more accurate, it is much more precise in nature. There's also heat, vibration, and bone noise, which and the vibrations which are felt by the patient, which generally contributes to some amount of discomfort and fear in the long run. It also creates anxiety. But micro air abrasion is more or less heatless, vibrationless, and there's minimal sound which is produced, and the patient apprehension and basically the patient acceptance is much higher in cases of micro air abrasion. There's also pain which is generally generated due to the vibrations of the drill, which can be negated using your micro air abrasion. There's also pinpoint production of some amount of static electricity, which is generally dissipated in cases of air abrasion. So the value, there's a lot of benefits. So there's reduced need for anesthetics, reduced patient apprehension, and then there's rapid cutting. So we are efficient and effective at the same time. It's highly precise, lesser heat, better bond, and you can work in all the quadrants with increased efficiency. And there's minimally invasive cavity preparations that you can deliver. So there are certain limitations. However, each technique or device comes with its own limitations. So can you guess what is the contraindication for air abrasion amongst the following? So we have severe dust allergy, asthmatic patients, patients with basically chronic obstructive lung disease or granulomatous reactions, people who have dermatological problems or recent extractions, those who have undergone recent oral surgeries, open wounds, or is it patients who have advanced periodontal disease or gum disease, or recent placement of orthodontic appliances. So the contraindications for air abrasion is actually all of the above. So none of these patients can are the right fit for using air abrasive units, because the powder particles can effectively irritate the open wounds. It can irritate any extraction sockets. It can also cause more aggressive periodontal disease in cases where there is already a persistent periodontal recession or disease. Also, in patients with dermatological problems, they can have asthmatic problems. Those people can have allergic reactions, and also where recent restorations have been done or recent placement of appliances. Or in cases of subgingival caries removal, it is not recommended. It is always recommended to use this technique with rubber dam isolation. It is very essential to use rubber dam while using air abrasive units, and the reason is because when we are doing air abrasion, there's powder particles which are generated, which are very very fine, and these can enter into our sulcus and cause gingival irritation or inflammation. So that is the reason we have to use air abrasive units with rubber dam isolation only. Okay, I see a couple of people being active right now. That is great in an afternoon session. So we have Jaidev and Vaishnavi who are answering our questions. So yes, it is all of the above. All these are contraindications, and the limitations is that it requires experience and precision. The greater distance, as I said, can cause lesser efficiency, and shorter distance can cause higher cutting. There's also interference with the visibility of the cutting site, because there's a lot of powder which is being sprayed all over the working site, because of which the visibility is reduced. Also, the dental mirror, that is, our mouth mirrors, can get etched, and the wear and tear of the mirror increases, because of which we need to replace our mouth mirror heads very often. And also, inhalation of the dust by the patient or the office personnel is always a health hazard. So that is the reason why I said rubber dam is essential. Use high vacuum suction devices while using air abrasive devices. So I hope this has thrown light over something which is new, something which is current, something which is more minimally invasive and you guys have not seen yet. I would advise all of you to check out some YouTube videos on air abrasive polishing for you to get a better idea and a visual a picture as to how this thing works. Okay, so let's move on. These are the different techniques in ultra conservative dentistry. We have just spoken about air abrasion right now. This is a table which kind of sums up everything. You have lasers which are coming in next, and then we have hemomechanical agents, pit and fissure sealants, remineralization, and alternative restorative treatment. So lasers, we have soft and hard tissue lasers. The soft tissue lasers are mostly diode lasers, or you have argon lasers and carbon dioxide lasers. So these are mostly used for soft tissue. We have erbium YAG lasers and erbium chromium YSGG lasers, which are used for hard tissue cutting, that is cavity preparations, can be done using erbium based lasers, right? So there are different wavelengths. So all these lasers have different wavelengths. They operate based on their wavelength, power, amplitude, and frequency. We will speak more about them in the further slides. So we also have chemomechanical agents, which is extremely interesting. It can be done with almost very minimal use or no use of any high speed drills, but they are extremely effective in disinfection as well as degradation of any decomposed or decayed carious tissue. So chemomechanical agents such as Papakeri, Caridex, Carisolve. In the recent times, we have Brix 3000, which has been introduced. We also have um, the new carry solve system. So we'll be discussing all that. Very interesting topics. All right. So we have pit and fissure sealants, which are prophylactic treatments in order to seal off those stained pit and fissures or demineralized pit and fissures. We also have remineralization gels. I want you to read about this in public health. You'll be covering a lot about remineralizing agents. Even in conservative dentistry, fluorides, we have ACP, and then we have APF, we have sodium fluorides, we have CPP, ACP, we have a lot of developments in the natural remineralizing agents. We have grapeseed extract and a lot of such natural extracts being used for remineralization of enamel and decayed tissue. We also have alternative restorative treatment, which is either to seal off the pits and fissures or to restore those cavities, and just hand instruments are used. Bulk caries removal is done and then restored with glass ionomer cement. So this is just to throw light on the various minimally invasive dentistry that is being carried out around the world right now. So another question for you guys. So which of these is not a component of the carry solve gel? Okay, I'll wait for about 2 minutes before I tell you the answer. So let me just tell you a little bit about chemomechanical caries agents before we proceed. Until then, I want you all to answer this question: which of these is not a component of carysol gel? Is it glycine, lysine, leucine, or glutamic acid? Jaidev, you have answered leucine. I'll wait for another minute or two for others to answer. Please kind of get this right. We'll have a little bit of a discussion on chemomechanical caries removal. This is a poster that I had designed during my post graduation. I found this topic extremely interesting. Something just like a liquid or a gel can be placed over a cavity and then just scooped off, and all the caries is removed, and you have a clean cavity. How interesting is that? So it all started off. So this is a timeline poster that I made. I want you to just listen for 5 to 10 minutes so that I can give you a lot of information on chemomechanical caries removal. Okay. So it all started off way back in 1972. There was an increasing trend and need for preserving natural tooth structure, and as this name suggests, chemomechanical caries removal. So there is a chemical that is chemo, and then mechanical, which is our hand instruments, or any kind of very low, ultra conservative, low invasive mechanical instrument, which is used to remove that chemical along with the degraded tissue to have a clean cavity. So that is what the name suggests. There is application of a chemical solution to the carious dentine. Okay, we put some gel, we put some liquid, and then we remove it with a gentle kind of a motion using hand instruments. So this has been very efficient in its caries removal effectiveness, and at the same time we are retaining all the healthy tissues. So we are removing only the infected dentine, retaining all that affected dentine. So let's kind of walk the journey of the various chemicals that have been tried and tested over the past few decades. It all started back in early 1970s when sodium hypochlorite and EDTA were used. These are normal RC irrigants that are used. So these were used to kind of disinfect the cavity. Very effective, but the thing is they don't really remove caries very effectively. They are very I would say non-specific in nature. That means that they just disinfect the cavity. They don't selectively remove decayed tissue. So that is the reason why these were rendered non-specific. Then we have 1976 GK101, which was introduced. This was by Goldman and Cronman, who decided to incorporate that sodium hypochlorite, what they used earlier. They put that into a buffer solution. So that buffer solution is known as Sorensen's buffer. All right. Remember the name, it's called as Sorensen's buffer. So they put sodium hypochlorite into the Sorensen's buffer, and this buffer contained glycine, sodium chloride, and sodium hydroxide. Okay. So it contained three things. It contained glycine, it had sodium chloride, and it had another solution which is known as sodium hydroxide. So all these three, along with sodium hypochlorite, helped in removal of a lot of decay. But the problem with this was it was not very effective in removal again. There was chlorination of the glycine in the denatured collagen, which was seen, that is the collagen from the decomposed dentine. That there was chlorination of the glycine molecule in that. and this formed something called as N-monochloroglycine, that is NMG. All right, so that is why this reagent subsequently known it came to be known as GK101, which is the prototype liquid, out of which Caridex was made, which is GK101E. This also helped in chlorination and disruption of partially degraded collagen. Okay, and this particular solution was basically invented by a person called as Shucks Bank. So what they did was they had two solutions. One solution had sodium hypochlorite, the second solution had glycine, and it had aminobutyric acid and sodium chloride along with it. So they had the Sorensen's buffer, which was used in GK101, but instead of using the glycine in that, they replaced it with aminobutyric acid along with a little bit of glycine, and this was known as Caridex. Now, Caridex was the problem with this was a huge solution. Almost 5 liters of the solution had to be poured into that one small cavity in order to remove the decay. Okay, which is a high high quantity to be used on a small cavity. So they decided to make it into a gel. So the this gel was called as Carisolve. This was made by this team called as basically called as Mediteam. All right, so from Sweden they made this gel, which is a pink gel, which is applied onto the cavity, and then spoon excavators are used to scoop away the gel, and this became revolutionary. Carisolve is one of the best materials which has been used in chemomechanical caries removal. It has sodium hypochlorite in one syringe, and in the other syringe there is a pink viscous gel which has three amino acids. Coming back to our question, those three amino acids are lysine, leucine, and glutamic acid. So the first gel is the same thing, which is our sodium hypochlorite solution. The second syringe was a gel which contained three amino acids, lysine, leucine, and glutamic acid. Along with these three, they put something to hold all these three together, and that is known as carboxymethyl cellulose. It's cellulose, right? So it is something which is like a gel. It is a viscous material, and thus this is easier to put onto the cavity. They also put a dye along with these three amino acids and along with the carboxymethyl cellulose. That dye is called as erythrocin dye, so that we can see that pink color more easily from a distance. So this is now an excellent gel which is being used. It surpassed all the limitations of the Caridex. So Caridex, a huge solution was required, almost 5 ml. It also required a delivery system. Can you see the delivery system? This was the delivery system to pour that liquid inside. It also required heating of the solution in GK101E, but that was solved with Carisolve. No heating is required, no delivery system is required, and it can be done very easily with very little amount of gel. So now the answer we know is lysine. So that is not the component of Carisolve gel. Yes, Jaidev and Vaishnavi, you guys are right. Lysine, leucine, and glutamic acids are the components of Carisolve gel. Next, we come to Papa Keri. Okay, so Papa Keri is something which is very interesting because it has the papain extract, which is from the papaya tree. The papaya that you know, the Carica papaya, that has that papain enzyme, which is incorporated into the Papa Keri gel. So this was introduced in 2003 by Busadori et al., who made a gel which consisted of that papaya extract, that is papain enzyme. It also had chloramine in order to degrade the collagen from the demineralized tissue faster. It also had toluidine blue to make it a blue, greenish blue gel. It had salts, some preservatives. It had a thickener to make it more viscous. It had some stabilizers and deionized water. So this Papa Keri causes degradation of proteoglycans of the dentinal matrix. So the dentinal matrix, which is there, when there is degradation of the proteoglycans, it can be easily removed, right? So that is the function of papakeri. The main action depends on this presence of the papain enzyme, which is the papaya extract. It is a proteolytic enzyme which has anti-inflammatory actions, and it is also bactericidal. So the papaya enzyme which is there is actually bactericidal, because of which it helps in the disinfection of the cavity. It also has anti-inflammatory action, which helps in numbing down the pulp. It also helps like a liner, right? But it cannot be left back under your restorative material. It has to be flushed away. But that amount of time which is there in the cavity, it helps in reducing the inflammation of the pulp. So it is extracted from the latex of the leaves of and the fruits of the green adult papaya tree. So from the latex of those leaves and fruits, this papain enzyme is extracted, and the chloramine is also added to remove the denatured tissues. So this is papa keri, and there is a very similar gel which was made in India then, called as Cari Care, right? So papa keri was then added with so the papain enzyme from the papa keri was used, and then along with that they added that Indian touch, which is our something which we have in our day to day lives, the clove. So the clove oil is used along with the papain enzyme to create a natural chemomechanical caries removal agent known as Keri Care. All right. So Keri Care is a more recent minimally invasive method for chemomechanical caries removal. It was developed actually in Chennai. It was developed by Unibiotech in collaboration with Vital Malia Scientific Research Foundation. Just some background information for you guys to make it more interesting. It's our Indian product. So this is also a gel-based formulation. It contains a purified enzyme, all right. So that purified enzyme is our papain enzyme. It also has the benefits of clove oil. So now, just a general question: can someone tell me in the comments what is the action of clove oil? So we've seen clove in toothpaste. We have seen it in a lot of dental products. We have seen patients who keep clove whenever they have some kind of tooth pain, or in case they have some kind of an oral irritation, they do keep clove. So do you know what is the action of clove? Even though it can be detrimental for the soft tissues if kept for a long time, uh, does anyone know the benefit of clove oil? So we have Jaidev who's answering. Very good, Jaidev. It is definitely an analgesic, so it helps in reducing the pain. There's another property of clove. Can someone say what that is? It's a very numbing kind of an effect that it has. So it, along with an analgesic, it also has some amount of anesthetic effect. All right, so it has that slight numbing effect on the pulp, and that makes our cavity preparation and cavity disinfection much more comforting to the patient. So this involves this papaya extract helps in breaking those peptide bonds, and it also involves deprotonation of the cysteine and the his basically those DNA bonds are broken down. Those peptide bonds are broken down in the degraded collagen by the papain enzyme. And our clove oil, as Jaidev said, is it's an analgesic, and we also have its anesthetic properties which are helping along. So that completes our carry care. Then we have another product called as Biosol. So this was an experimental product which was made by 3M in 2006. It claimed that they had phosphoric acids and they had a biophosphonate buffer, but this is still not in the market. We then come to the final system, which is the new Carisol system. So the new Carisol system is an upgraded system to the previous Carisol. So we had the previous Carisol with a gel, and it had to be used with hand instruments. So now the new Carisol system came with its own set of specialized hand instruments for cutting. Spoon excavators, it had other hand excavators with blunt cutting angles, and they also came up with some tissue preserving burrs. All right, so it had a gel which had to be placed for 30 seconds in the cavity, followed by its excavation. So for excavation, you could use the hand instruments, or you could use these minimally invasive burrs such as CeraBur and POLYBUR. It had to be left for 30 seconds within the cavity uh, in case there was any soft tissue remaining. And then you can also use some amount of curing light. So the curing light helps in detection of any residual decay or any residual infected dentine. So they had a particular photo sensitizer which was added, a detector, a photo sensitive detector which was added to this gel. So this detector gel along with the caries removal gel helped in effectively removing all the decay. It also came with its own specialized hand instruments and its own burrs. All right. So this is the new CARISOL system. This came in 2013 by Rubicon Life Science, and it's an advanced gel, a new excavation technique, and they came up with a new patented caries detector, which can be detected using your curing light as well. So, can someone identify the object in this picture? Is it a polyburr, ceraburr, carbide burr, or a polishing burr? So, this question is the one which was asked in our previous NEET exam. So we have Jaidev only being so active. Vaishnavi, you can join into. Anyone else who is there can answer as well. What is this object which is there? Is it a polyburr, a ceraburr, a carbide burr, or a polishing burr? Uh, Dia Sarkar is asking if it's a ceraburr. We'll just wait, right? So we have this new carry solve system which comes with a ceraburr and a polyburr, right? So you can see the ceraburr is white in color, looks more hard. The polyburr is more plastic, looks blue in color, right? So we have Vaishnavi answering it's ceraburr. Saransh thinks it's ceraburr. So the object in this picture, I just kind of showed you the photo right over here. I'm not sure if it's clear enough. You can see the ceraburr is white, the polyburr is blue, right? So Maithili is saying abundant. I'm not sure what that means. So the object in this picture is a polymer. Yeah, Vaishnavi, you're right this time. It is a polymer. Jaidev, I'm happy you know and you identified this in the first go. These are various sizes in the polymer. A polymer is basically a plastic burr, very highly minimally invasive, hardly cuts any tooth tissue. Jaidev, yes, exactly. Smart burr is similar. It is green in color. Very good that you know that. So I have the photo of that as well. The smart burr is a polymer itself. They are just marketed differently with different names, but effectively, if you ask, they both do the same. So you see the smart prep burrs. The smart prep burrs are these green color ones. The polymer is the one which is blue in color. So the smart prep burr was by SS White. The polymer is by Comet Dental. If you want to just have a little more background information on that. So the smart prep, which is the green burr, what you see over here, this is by SS White company. Okay. Yes, it did come in this year's NEET, and that is the reason why I am so very highly insistent that you guys understand this topic very well. It cuts only infected dentine. The affected dentine is remained. It's left behind. It's left intact to remineralize. We have the Smart Prep SS White Burr, which consists of a polymer known as PEKK. Again, guys, please remember this particular compound. That is the composition of a smart burr. It is a polymer known as PEKK, which is polyether ketone ketone. Okay. Now, how this works? Okay. I just want you guys to again listen to me carefully. You have healthy tissue, which is extremely hard. You have soft tissue, which is decayed tissue, which is extremely soft. So soft carious dentine is there. You have hard intact tissue, tooth tissue. Okay. Now when any of our burrs, that is our diamond burrs or our tungsten carbide burrs or any of the regular aeromotor micromotor burrs that you use in your day-to-day practice, when you place this on the cavity, it does not differentiate between soft decay and healthy tooth tissue. Please remember that our diamond burrs are high cutting. They are meant to cut through tooth. They are meant to cut through enamel and dentine. Enamel, being the strongest part of our body, has a very high hardness level, hardness number. The hardness number is measured by KHN, that is Knoop hardness number. Now, this is the um, principle or the ideology behind using a polyburr. The polyburr is not as hard as tooth. It cannot cut through enamel. It cannot cut through dentine. It can only cut something which is softer than that. Something which is softer than a plastic burr is nothing but decay in the cavity. That is soft demineralized dentine. All right, remember this: soft demineralized dentine is what is softer than the smart burr or the polyburr. I want you all to answer right now in the live chat, what is the Knoop hardness number of decomposed or demineralized dentine? Can someone tell me the Knoop hardness number of demineralized dentine right now? Until then, so as I said, the polymer is much harder, all right, than the hardness of the demineralized dentine. Demineralized dentine has a hardness level, a KHN of something below 50. Obviously, because polymer is 50, so the demineralized dentine has to be softer than polymer. Any of your hard tissue, healthy tissue, is above 50. So your dentine, for example, affected dentine is somewhere in the range above 50. So I'm very happy, Jaydev, that you know the no partners number. It is 20 to 25 for soft dentine. That is demineralized dentine. Anything lower than 25 is the mark. 20 is lower than that. So yes, yours is right as well. But 25 would be the ideal answer for anything which is infected. So anything which is infected is lower than 25. Okay. Now I want you all to tell me what is the Knoop hardness number of affected dentine. What is the Knoop hardness number of affected dentine which is more than 50? Okay. So let's get back to the slide. We have the polymer burrs which have tiny polymer flutes. Okay, those flutes are very small, so it wears away as soon as they touch the healthy hard dentine. So if they come in contact with healthy hard dentine, they start wearing off. So that is how self-limiting they are. This self-limiting feature assists in ensuring that only the decomposed dentine is selectively removed, not the healthy hard dentine. So there it wears away. Only when it comes in contact with soft tissue, it gets excavated. So excavate caries using this burr from the center to the periphery in order to avoid contact with soft tissue. Otherwise, the burr will get prematurely damaged. All right. So make sure you go from the center of the cavity where you have the highest amount of necrosed tissue, highest amount of decomposed dentine. You go from there to the walls of the cavity where you have healthy sound tissue left. Right. So that is how polymer works. So I'm just giving away the answer. The Knoop hardness number, yes, it is 20 to 25, 25 for demineralized dentine. For that of affected dentine, it is 75 onwards. All right. So the Knoop hardness number of polymer is 50, which is in between 25, that is that of a decomposed dentine or infected dentine, and 75, which is that of affected dentine. So Knoop hardness number of polymer is in between, which is 50, because of which it cuts only infected, retains the affected. So the answer for this is polymer. Knoop hardness number is 50. The material used is PEKK, which is polyether ketone ketone, and it is self-limiting. It starts wearing away when it comes in contact with healthy tissue. Now, there was a study which showed that there was more residual caries which was found in cavities excavated with these smart burrs in compared to TC burrs. All right. So why is that the reason? Obviously, because it is removing only the soft decomposed dentine. So more residual caries was seen, but the caries was mostly seen to be affected. Very limited amount of infected dentine was remaining. That is the reason why it is essential for you to combine your plastic burrs or your poly burrs along with a caries removal gel, such as the carry solve or the carry care or the papa carry or the carry solve old agent, or any of these can be used. Even the new bricks 3000, so bricks 3000 has something called as an encapsulated buffer solution, which is much more effective is what they are claiming. So the bricks 3000 is a new gel which is used, approximately 3000 rupees is what I'm guessing. Last remember it to be priced at. So not a very expensive gel. You can use those on more than 5 to 10 cases, and you can effectively remove gel with a very high patient comfort. So in addition, not only the microtensile bond strength to caries dentine excavated with smart burrs was lower, but it was also seen that there was more amount of uh, bonded interfaces which disclosed remnants of caries tissue. There was a lot of caries tissue which was remaining, and thus it was suggested that the efficiency of polymer burrs could be enhanced if the hardness of the polymeric material could be increased. So that is the reason why I am saying that instead of increasing the hardness of this, it is better to use something in conjunction with that, such as a caries removal gel. You can also use Cera burrs. So instead of using your diamond burrs or your tungsten carbide burrs to gain access into your cavity preparation, it is better if you can use something which is still high cutting efficiency, but it again cuts only mostly infected and soft dentine. It doesn't really cut your affected dentine as much. It also doesn't cut on your healthy tooth tissues so much. It is just to gain access in order to remove any undermined enamel. These are used. They are all ceramic burrs used in slow speed, and they're made out of alumina yttria stabilized zirconia. I want you all to note this down. Make a note of the composition of Cerabur. It is alumina yttria stabilized zirconia, which is an all ceramic burr made out of only ceramic material, which is zirconia, and it is stabilized, which makes it a stronger material. So it has high cutting efficiency. It makes your procedure much faster than using just plastic burrs. So the use of this instrument replaces both the explorer and the excavation spoon, that is your spoon excavators, because it gives you the tactile sensation. The problem with diamond burrs or TC burrs is that you lose that tactile sensation. You're just cutting through it, as I said, as a knife cuts through butter. So that is the reason why you shouldn't use something like an aeroter burr. Instead, you should stick to something which is all ceramic, or something which gives you that tactile sensation when you're touching the healthy tooth tissue. So it is self-evidently reducing the preparation time because it gives you a higher tactile sensation. So this did not show any significant difference. That is, caries removal efficiency stayed the same, its efficacy stayed the same when compared to a TC burr or a diamond burr, which makes it effectively very good for us to use, because if there is no difference in the caries removal efficiency, you can stick to a Cera burr in the superficial parts of your caries excavation. In the deeper aspects where you have very little bit of demineralized dentine, where you're very close to the pulp, you can switch over to your polyburs, and help in that will help in self-limiting it from the a healthy tooth tissue. So you need to be very ultra conservative in your preparation while using these burrs. So as I said, uh, these two burrs along with the chemomechanical caries agent. These two burrs were by Comet Dental, that is the company, Cerabur and Polybur. This is for superficial excavation, this is for deep excavation. Along with your gel is a complete kit for your ultra conservative cavity preparations. So now let's switch over a little bit of light on veneer preparations, right? So ultra conservative principle applies everywhere. It applies to aesthetic dentistry, it applies to restorative dentistry, and in the next few slides we'll see how it is even applied to endodontics. So the ultra conservative technique for veneers involves minimal tooth structure removal. That is, it is highly respectful of the healthy dental tissues and highly aesthetic, making it potentially beneficial to both the patient and the dentist. So everything relies on maximizing the bond strength. We all know that enamel gives you a better bond strength than dentine does. That is the reason why we need to preserve all that buccal enamel as much as we can. Wherever a little bit of dentine invasion is required, there only it has to be done. Otherwise, we are looking at minimal or no preparation veneers. So the indications for ultra conservative dentistry are best revealed by considering when ultra conservative dentistry is not indicated. So basically what they're trying to tell by this line is that we need to be ultra conservative or minimally invasive wherever possible. We need to see where it is not indicated. It is not indicated in cases where more invasiveness is required, in cases where there is more amount of discoloration, where there is intrinsic stains which are there, where we need more amount of retrusion, or basically intrusion of your teeth. In those cases we need to be a little more invasive. So let's switch over to lasers right now, right? Veneers was just to make throw some light. There's a lot behind veneer preparations that need to be learnt about. We can have a separate session on just veneer preparations and veneer designs. Right now, let's come back to ultra conservative dentistry. I want you all to answer this question: which of the following is not a soft tissue laser? I've already given you the answer in the previous slide when we were discussing that table on the various ultra conservative preparations. So Jaidev thinks that diode is not a soft tissue laser. Uh, let's wait and see if it is. So let's just wait for the answers, and I'll throw some light on what a laser is. So a laser is you. So you all know the full form, right? It is light amplification by stimulated emission of radiation. So in that, there's a laser unit which has a fiber, all right. So that laser is directed towards the carious dentine or towards whatever tissue you want to cut. So once the laser beam is activated and irradiated, the beam comes into the cavity, and the water molecules in that decay gets heated up rapidly, and that results in increased pressure in that local environment. So whenever there is so much amount of energy which is focused on one area, on one particular region, there is a lot of energy which is delivered to that one small area, because of which there is that increased pressure will cause disruption of the area and the subsequent adjacent molecules. So the water molecules inside this decay gets heated up rapidly, and that disrupts, creating an explosion, micro explosions of various sites, and that will effectively remove the decay. So this also helps in killing the bacteria, as there is so much amount of irradiation of a laser beam in a specific area. There is also bactericidal effect, so the tooth is sterilized and it is delivered clean. So we have Saransh who is suggesting that the answer is erbium YAG. Very good, Saransh. The answer is right. Erbium YAG is not a soft tissue laser, it is a hard tissue laser. Remember, guys, erbium, ER, this is hard tissue. All right, erbium chromium, it is both. You can even do soft tissue excisions with it, but it is mainly a hard tissue laser. Erbium YAG and even erbium chromium YSGG laser, both of these, the erbium family of lasers, are hard tissue lasers. Diode, ND-YAG, carbon dioxide lasers are all soft tissue lasers. So oral hard and soft tissues have a specific affinity for the wavelength. So the wavelength decides which laser it is. Is it a hard tissue or is it a soft tissue? Higher wavelengths are for hard tissue. Lower wavelengths are for soft tissue. So oral hard and soft tissues have a specific affinity for absorbing laser energy of a specific wavelength. So the wavelength of a dental laser is the deciding factor what the absorbing target tissue is. The principal effect is photothermal, which means that there is light and there is heat which is generated. The light is what is generating the heat. So there is a monochromatic, that is a single color, single wavelength, coherent, which means all the beams are focused on one area and it is collimated. They are all parallel, all streamlined into one specific area, into a single wavelength. All right, a single wavelength light is delivered, and all these light waves are in a single phase. They are not in different phases, they are in a single phase, and this precise beam is then delivered or focused on one area in one direction, which causes concentration of a huge amount of energy to a very small precision area, which is why lasers are probably known as the magic wand of dentistry, because they are the true ultra conservative tool to have in your practice. Soft tissues, in soft tissues, the water content is high, and thus it helps, laser helps in excision of the soft tissues. In cases of hard tissues we know, as we know, is composed of hydroxyapatite crystals, a lot of minerals such as calcium, phosphate. These are not ablated at this temperature, which means they are not burnt, they are not completely burnt in this temperature. That is the mineral content, and these crystals are not burnt at this temperature, but the water component within them, the water which is present in the hydroxyapatite, the water which is which is present in our uh, dentinal tissues, these vaporize, and the resulting steam which is produced expands and then disperses the encompassing material into small particles. So let's just take a step back over here, and I'll kind of make you understand in this way. You have one device, a small pen, okay, and then you have high amount of heat coming out of that pen. Okay, imagine that there's a flame or a fire which is streamlined like a flame gun, and now you're placing that in a enclosed cavity which has some amount of water, and that is like a pressure cooker. So once you put the flame over there, the water within that pressure cooker kind of becomes much more um, um, heated up and converts into steam. This steam then helps in disrupting the particles when the steam pressure becomes excessive. So that resulting steam expansion breaks the cooker lid apart, breaks the cooker vessel completely into different pieces. Now, that cooker is nothing but our dentinal tubules or your hydroxyapatite crystals or any of your tooth tissue. The water is the water within it, and the flame is our laser. So it is basically a small example for you to understand the amount of difference that water content in our dental tissues is making, because it converts into steam and then explodes, creating that disruption of the hard tissue. So this is a table I want you all to take a screenshot of. This throws light on the different types of lasers, the wavelength of each laser, what tissue it acts on, is it soft or hard, and what are the various examples. So over here we have the first one, which is the diode laser, 800 to 900 nanometer. It says that it acts on both soft and hard, but it is mostly just soft tissues. When it comes to hard tissue, it has very limited effect. It can help in desensitization of the hard tissue. It can help in a little bit of calculus detection and caries detection. It can help in a little bit of TMJ disorder treating, but it is mostly soft tissue, crown lengthening, sulcular debridement, removal of the tissue from orthodontic brackets, troughing for crown and bridge in case you want to trough selectively, frenectomies for excisional biopsies. Even for tooth whitening, you can use diode. So all these are the different examples of the uses of the diode laser. We have the ND-YAG, which is also used for soft tissues, 1064 nanometers. Sulcular debridement, it is also used for the LANAP procedures, that is your periodontal procedures. We have the tissue retraction and biopsies as well. We have the erbium family lasers, which is used for cavity preparation, for calculus removal, for endodontic procedures, for sealant preparation, for osseous surgeries, for aphthous ulcer treatment, for cavity preparation and root debridement and scaling. You can even use them for your cavity disinfection and for pulp capping procedures. We have carbon dioxide lasers, which are used for soft tissues again, and argon for soft tissues. Diode lasers can also be used additionally for pulp capping. Indirect and direct pulp capping can be done. I've extensively used lasers in my post graduation for pulp capping cases, and the final results that were delivered were truly remarkable. Uh, a laser used directly over uh, exposed pulp, which is lesser than 1 to 1.5 mm. The laser fiber will basically cause hemostasis of that region. It will cause coagulation of that region. It will close the cavity in those areas, and it will also help in recovery of the pulp from inflammation. On top of that, when there's a bioceramic material such as mineral dioxide aggregate or biodentine which is placed, it effectively helps in preventing the tooth from an endodontic treatment. So the laser irradiation might reinforce the enamel structure. So it also helps in reinforcing the enamel. It causes the physical fusion of those crystals, reduces the enamel solubility also. So this decreases sensitivity, hypersensitivity, and this helps in melting, sealing, and recrystallization of those hydroxyapatite. Okay, so ultrastructural alterations in the enamel can help in reduced enamel solubility, and this will help in our reduced sensitivity for the patients. All right. So in cavity preparations, we can see that this erbium YAG laser is placed over the cavity, and the tip is moved up and down in a pumping action. So that pumping action helps in placing the laser beam in a specific area and focusing it and pumping it with more amount of intensity in order to help in the expansion of the water within them. Different tooth structures can be detected by hearing the sound of ablation. So even the sound of the heating which is happening can help us in differentiating whether it is soft tissue or hard tissue. Whenever it cuts on hard tissue, you can hear that there is a screeching kind of a sound or large a high scraping kind of a sound. But when it is placed on soft tissue, there is a gentle whizzing kind of a sound which is heard. During interproximal tooth preparation, adjacent teeth can be isolated, so you can use these on class 2 cavities as well. The laser is capable of ablating and preparing the cavity in an irregular fashion, which is ideal for the placement of composite or glass ionomer. It is a minimally invasive procedure, and there's hardly any decay which is left behind. Another question for you guys. We're coming to almost the end of this presentation. I want you all to understand that ultra conservative dentistry is not just one particular technique. It is a mindset, it is a philosophy that you follow, that the dentist follows. The dentist wants to be as preserving as possible. Imagine yourself as the patient. If you were the patient, you would want very little tooth tissue to be removed, right? So it applies to restorative dentistry, it applies to preventive and pediatric care, it applies even for endodontics and aesthetic dentistry. So modern access cavity preparation guidelines focuses on preserving a lot of tooth tissue, which is extremely important. So there is a hierarchy of tooth needs, which means that specific areas, certain areas of the teeth have to be preserved more than the others. So the modern access cavity preparation guidelines focuses on preserving that part of the tooth which is extremely helpful in retaining it in the long run. So after a root canal treatment, we know many cases where the tooth fractures under load even after a crown is placed. That is because of a big access cavity which is prepared, because of a lot of troughing which is done, lot of gouging which is done at the neck of the tooth, where the CEJ is present. So a lot of gouging and drilling of the teeth in those crucial areas, I would say, is detrimental to the long term success and structural integrity of the tooth. And for that reason, modern access cavity preparation guidelines were given by, take this name down, it's called as Clark, that is David Clark, and John Cardemi, that is John followed by Khademi, Cardemi. All right. So John Cardemi and David Clark are two restorative dentists and endodontists who thought about preserving teeth as much as possible by reducing the size of your access cavity and making sure that it is enlarged only where it is necessary and not where the tooth is important and crucial for long term success. So we have Dr. Saransh, who thinks that pericervical region is the most important. He also said secondary dentine prevention. So I want you to tell what is the answer. Saransh and Vaishnavi both again think that it's secondary dentine which is important. So modern access cavity preparation suggests that the highest value for a particular tissue type is that for the pericervical dentine. So that is C. All right. So you were right, Jaidev. It is C, that is pericervical dentine. Saransh, again, your last answer was right. Pericervical dentine is crucial for saving the tooth in the long run. The next important is the undermined dentine. Any amount of that is the D2J, that is the junction where the primary and secondary dentine join, the axial wall DJ, and the cervical enamel in cases of physiologic young teeth, because a resorption can happen or even a root caries can start. Does the hierarchy of tooth needs suggest that the highest amount of importance be given to the pericervical dentine? The least importance is for tertiary dentine, for undermined enamel, for any CJ in physiologically aged tooth. So this is the pericervical dentine. What you see over here, what I'm marking with my laser pointer, that is the PCD, which is about 2 to 3 above the CEJ and about 1 to 1.5 below the CEJ. So this area is the most crucial for saving in the long run, because this is the area which will give you long term stability. So the ninja outline or the ultra conservative ninja access cavity preparation suggests that this red box be your access cavity, that smaller hole for accessing all your root canal orifices which are beneath it. If you see this trapezoid over here, the black dotted line, this trapezoid is what was suggested in your traditional access cavity designs. That is, this box is the amount of dentine which has to be removed, the enamel and dentine which has to be removed in order to gain straight line access into your root canal orifices. But ninja access cavity is in the age of microscopes, adhesive dentistry, and in the era where there's a lot of ultra conservative need, where we can save a lot of tooth by preserving maximum amount of tooth structure. We are able to give just a direct fiber reinforced access cavity restoration, or you can go for cuspal coverage only, like a tabletop or an onlay or an overlay, instead of going for a full crown, because a full crown invades into your pericervical dentine. Your full crown would require you to effectively enter this area which is outside, all right, where your dentine would get compromised, and this would help in preserving the tooth in the long run. So your red line is what is your ninja access cavity preparation. The green line, what you're seeing in the left image, is the contracted access cavity preparation, which is kind of a midway between a ninja access and a traditional access. So somewhere over here you can see all the three being placed over here. The trapezoid is the traditional access cavity, the green line is your contracted access cavity, and the red being your ultra conservative or ninja access cavity preparations. Over here in this image, you can see again this dotted line is your traditional access cavity preparation, which dictates that you need to have a straight line access till your root canal orifice. All right, you need to have a straight line access. You need to flare up your access cavity preparation and remove all this amount of dentine, which is actually crucial in holding this tooth for the long run. That is why traditional access cavity is now being replaced by contracted or ultra conservative or ninja access cavity. Contracted saves this amount of dentine which is there. This is known as soffit. Okay, just a little bit more information for you guys. It is known as soffit or soffit. Okay, so this is that little amount of uh, tooth or dentine which is covering your roof. All right, so basically let me show you this area over here. You can see this small green L shaped area. This is known as a soffit. That is your pulp chamber roof. Okay, so your pulp chamber roof is not completely de-roofed. So your traditional access cavity dictates that the pulp chamber should be completely de-roofed and smoothened out into all the line angles. But your contracted and ninja access cavity preparation designs dictate that this soffit be preserved as it is, so that this will help in increasing your PCD, which is the highest in the hierarchy of tooth needs, that is your pericervical dentine. So that is preserved by preserving this soffit. All right, so that there is a roof which is circling like an internal ferrule. All right, instead of a ferrule being on the outside, we also have a ferrule kind of an effect on the inside, so that this amount of dentine will help in structural durability of this tooth in the long run. So your access cavity decides your durability in the long run. So this ninja axis, that is the red line, and the contracted axis, both believe that PCD has to be saved as much as possible. So minimally invasive endodontic interventions highlight the preservation of natural tissues, require successful intersection of specific benefits, outweighing potential risks, procedure-driven technologies, and skill adaptation. What that means to say is, when you have that small an access cavity, the chances that there is a procedural error increases, because there is a higher chance that now your instrument may break. There's a higher chance that you may cause a perforation. There's a higher chance that you may transport the canal, or you may even miss out on extra canals or extra canal orifices, because of which this ninja access cavity is being questioned right now. And this green one, which is the contracted access cavity, is being given a lot of importance, because this effectively prevents a lot of healthy tissue removal, but at the same time helps in us locating all the root canal orifices, and also removing that little bit of pulp which may be present in these pulp horn areas, and that can also be effectively debrided using this contracted access cavity. So I just wanted to throw some light on this as well, because ultra conservative principles hail through all principles of dentistry, including prosthodontics, endodontics, periodontics, aesthetics, and even your restorative dentistry. So the conclusion is that the science and art are firmly on the side of minimal preparation. You being placed yourself, if you can place yourself as the patient, you would want as little bit of tissue removal to tissue removal as much as possible. So that is the reason why ultra conservative or minimally invasive dentistry is being given a lot of importance. I want you all to also read about tunnel approach or internal preparation for aproximal lesions, which means proximal decay can be removed without removing the marginal ridge. By preserving the marginal ridge, you can go from the mesial pit or the distal pit, the corresponding pit, you can go from there and tunnel through the enamel and dentine inside itself, and you can preserve the marginal ridge by accessing the cavity only through the uh, occlusal surface without interfering with your marginal ridge. That is how much your ultra conservative preparation has developed. You can use minimally invasive burrs and microscopes, and better magnification to get to that point. Magnification has a key role in minimally invasive preparations because you need to see what you are doing. Right, so the profession as a whole is moving in the direction of more conservative dentistry with lesser preparation and lesser removal of healthy tooth structure. So this benefits both the patient and ultimately benefits the professional and the profession as well. So thank you all for listening to us. This was intended to be a long session because we know the importance that ultra conservative dentistry has in the present pandemic era where there is reduced aerosol which is produced during these procedures. Lasers and air abrasion physiotherapy procedures generate very low aerosol while providing maximum patient comfort. So thank you all for listening. I want you all to go back to your books, read more about minimal intervention dentistry. There's a lot on remineralization. There's a lot on atraumatic restorative treatment, and also read through your different um, um, laser and other different quantitative aspects that they may ask based on this topic. Also, I want you all to solve the corresponding module that we have on our app. We have all the questions put up. So please go back to our app and solve as many questions as you can. I've given you the basic concept. Now it is up to you to take it from there, solve many questions and understand the concepts right from what they are basically made out of. So I hope you all have a great learning, and I hope this was a great session for you all to learn more about ultra conservative dentistry. Thank you all. Have a great day.